Bismillah ar-Rahman ar-Rahim. I will speak in this video about what's called latent TB infection. The definition: a positive skin test or interferon gamma release assay showing mycobacteria tuberculosis infection but with no signs, symptoms, or chest x-ray changes of active TB. This represents a presence of small total number of mycobacteria with the host immune system retaining control over mycobacterial replication. It should be distinguished from active disease, which is usually accompanied by symptoms and chest x ray signs of active disease, including infiltrates or lymphadenopathy. An estimated 1.7 billion people worldwide have latent TB. Treatment of latent TB with chemoprophylaxis reduces the risk of subsequent development of active disease by about 90%, but a proportion of people will be treated who would never have developed active disease. The tuberculin skin test, a positive skin test, results from the development of cell mediated immunity against TB. Potential problems with skin testing are low sensitivity in the immunocompromised and cross reactivity with BCG, and the patient has to return to have the test read after 48 to 72 hours. Criteria for a positive test depend on the population in which it is being used. On the population in which it is being used. Interferon gamma release assay, two blood tests, T-spot test and quantiferon TB Gold are available and based on the detection of interferon gamma released by the T cells in response to mycobacterium specific antigen. The T-spot test is an ELISA spot test counting individual T cell producing interferon gamma. The quantiferon test is based on a whole blood ELISA and measures interferon levels in the supernatant of the stimulated whole blood sample. Both assays use two proteins, ESAT6 and CFP10, encoded by unique genomic sequence of Mycobacterium tuberculosis, which is absent from Mycobacterium bovis, BCG, and the majority of opportunistic mycobacteria. These proteins the main tests are the main targets of interferon gamma secreting T lymphocytes in individuals infected with mycobacterial tuberculosis. And these tests have several advantages over the tuberculin skin test, which include no return to visit or no return visit for test reading is required, and the result is available the next day, and repeated testing does not cause boosting. With both tests, blood tests be collected in a heparinized tube and processed within 6-8 hours of venipuncture or venipuncture. The blood should be transferred to the lab at room temperature. Both tests are more sensitive for diagnosis of latent TB than the tuberculin skin test, particularly in children and HIV positive individuals, and no current available evidence there is little difference between the two, although the T-spot TB test may be more sensitive in HIV positive individuals. HIV and latent TB infection. The tuberculin skin test may be falsely negative and radiological changes may be atypical, and the current WHO guidelines recommend isoniazid chemoprophylaxis for HIV infected patients in low income and high burden countries with positive or unknown skin tests in the absence of active disease. Uptake of this recommendation is slow, partially because of the difficulties in distinguishing active disease from latent disease in the setting of HIV co-infection and the concern regarding emergence of resistant strains and exposure to smear positive disease should lead to chemoprophylaxis in the absence of active disease. Recommended follow-up is at 3 and 12 months for those not receiving chemoprophylaxis but who were eligible for it. HIV positive patients should receive long term follow up as a part of their ongoing HIV management. The chemoprophylaxis for latent TB infection it's given to contacts or screened immigrants with a positive skin test more or equal to 5 mm regardless of BCG status or positive interferon gamma release assay who have no radiological or clinical evidence of active disease, and the risk of developing disease after exposure depends on a number of factors, including BCG and HIV immune status and whether infection was recent. Younger patients must have had relatively recent infection and have a longer life expectancy from which to gain the benefits of chemoprophylaxis. Chemoprophylaxis is recommended for those aged below or equal to 65 years because of increased risk of drug hepatotoxicity with age, those with recent documented tuberculin conversion, and the HIV infected contacts of smear positive cases at any age healthcare worker, individuals with HIV injecting drugs with hematological malignancy, chronic renal failure, or on dialysis with silicosis, gastrectomy, solid organ transplant, or receiving anti-TNF alpha, anti-TNF gamma therapy have a higher risk of developing active TB. The drug regimen of chemoprophylaxis include rifampicin and isoniazid daily for 3 months, 3RH, improved compliance but slightly higher side effect profile. Isoniazid daily for 6 months, 6H, lowest toxicity regime, and has a 60 to 90% effectiveness in reducing progression of latent infection to clinical disease. 6H is recommended for people with HIV. 6R is recommended for contacts of patients with isoniazid resistant disease. Individuals who decline chemoprophylaxis should be given informed and advised information regarding TB risks and symptoms and have a chest x ray at 3 and 12 months.